locations of celiac plexus block. So you have dealt with nicely all these things. And just for the sake of a visual impact, so that all of you can remember what she has spoken in length about this, I just share this screen with you. So some of the important things. So once you see the pictures and the writings, it will be more easy for you to remember. I'm not going to add anything new to the what she has spoken. So, but just for the sake of good memory for you all, it will be better that if you remember this. Uh, so, celiac plexus is an autonomic nervous plexus and consisting of interconnected paraertic uh, ganglia located around the roots of the major abdominal aorta branches. So, there are smaller ganglia which are interconnected, and the whole of them together is called the celiac plexus. And it consists of three ganglia: the superior mesenteric and the renal celiac. These three are the important ganglia which are surrounding the celiac trunk, superior mesenteric, and renal arteries. And the ganglia are interconnected into smaller celiac, superior mesenteric, and renal plexuses, which together comprise one large celiac plexus. So there are three ganglia which are interconnected with small plexus. Plexus means a bunch of nerve or a crisscrossing bunch of nerves, and the ganglia lie on each side of the L1 or lumbar vertebra. Aorta lying posteriorly, pancreas lying anteriorly, and inferior vena cava laterally. This is the relationship of the celiac plexus or the celiac ganglia at the L1 level. The celiac plexus outsources both parasympathetic, sympathetic, and nociceptive fibers. It has got all the three components. Normally, we have sympathetic ganglia, parasympathetic ganglia, which are all separate in various other locations. Whereas the peculiarity of celiac plexus is it is a conglomeration of parasympathetic, sympathetic, and pain fibers also. That is why when it is affected, produces a lot of pain. And the parasympathetic input for this plexus is from the vagus nerve, and the sympathetic is from the greater and lesser splanchnic nerves. So these are the nerves giving the supply of parasympathetic and sympathetic, and branches of the celiac plexus reach their target organ by forming a very arterial plexus surrounding the abdominal aorta. Thus, the celiac plexus supplies the inferior part of the esophagus. So, majority of the abdominal organs, starting from the esophagus, stomach, pancreas, spleen, kidney, liver, gallbladder, and up to part of small intestine, were all supplied by the celiac plexus. That is why when any of these organs are affected, patient will have pain transmitted through this. So this is a picture. This is the diaphragm. So this is the aorta which is coming through the diaphragm, and the first branch of aorta is the celiac trunk, and closer to that you have the celiac ganglia. Then there is a superior mesenteric artery taking off below the celiac trunk, and you have a superior mesenteric ganglion close to that. And third, you have the renal artery taking off, and there is a aortic renal ganglia. So these are the three ganglia which together with the nerves which are interconnecting them, the whole thing is called the celiac plexus. So there is a celiac ganglia, superior mesenteric ganglia, aortic renal ganglia, all connected by the nerves, and the sympathetic supply, as I said earlier, is coming from greater splanchnic nerve, which is a nerve root of T5 to T9, lesser splanchnic T9 to T11, and least splanchnic T11 to T12. You can see all the three pierce the diaphragm and come and join the celiac ganglia. So all this supply having both, and the vagus also comes and gives a branch which is not depicted in this picture. So all these things together they form the celiac plexus. Now The function of celiac plexus is to transmit visceral sensory input and reflexes to the foregut and midgut, and it increases gland secretion and promotes peristalsis and digestion with its parasympathetic division. And the sympathetic division inhibits the peristalsis, constricts blood vessels, and redirects blood to the skeletal muscles. So that is why when there is a trauma or injury and hypovolemia, we always say blood is diverted from skin and splanchnic area to the vital organs. So that is done by the sympathetic division of which is actually constricting the blood vessels and transferring the blood, which is quite a huge quantity to the other organs. And the indications for celiac plexus is intractable abdominal pain, which is non-responsive to less aggressive analgesic intervention. So often these patients, if you have to treat them with pharmacological methods, you have to give them very high doses of opioid, especially patients with pancreatic cancer who have very severe pain. They all need a very high dose of opioids, which can be avoided by giving this block or ablating this celiac plexus. And the indications include intractable intra-abdominal pain, including pain in settings of malignancy or benign neoplasms involving pancreas, biliary tree, retroperitoneal organs, and other abdominal organs. Contraindications for this block are immunocompromised patients who have taken chemo or radiotherapy, where the possibility of infection, even if you do a very aseptic procedure, they are likely to develop an infection. So patients with coagulopathy or thrombocytopenia, where there is an increased risk of bleeding. So if you accidentally puncture some vessel, that will end up in a very large hematoma. So that will be a big problem. And patient refusal or inability to consent. Again, that is a very valid contraindication. And anticoagulation use or ongoing infection or abnormal anatomy. Some rare fracture or some surgery which has caused some alteration in the anatomy, then that is also a contraindication. Now, what is the technique? There are several techniques which have been described as retrocrural, transcrural, transaortic, anterior, and all these things. But the two most commonly used are posterior para-aortic approach and anterior para-aortic approach. These are the two commonly used techniques. Now, a diagnostic block consisting of local anesthesia should be performed before if you plan to do a neurolysis, then you have to first make sure that the block is effective by injecting local anesthetic. And patient will have immediate relief of pain once the block is successfully correctly done by blocking the celiac plexus. Patient who has been writhing in pain for a number of days or months will immediately have a big relief and he will thank you by the block done by the local anesthetic. And once you confirm that it is nicely working, then only you should attempt neurolysis. So straight away giving the neurolytic agent should not be done. And alcohol is preferred agent. Some people use phenol also. And what is the posterior para-aortic approach? Patient should be placed in the prone position with support under the abdomen to increase the kyphosis of the thoracic spine. And anatomical landmarks are midline spine and vertebral bodies, iliac crest, 12th rib, and lateral border of paraspinal muscles. These are all the structures that we have to first clinically make sure. And the patient's skin is disinfected and the area is properly draped appropriately. With the radiographic tools, identify T12 and L1 vertebral bodies. And the inferior border of the 12th rib should be identified and marked in a sterile fashion. A skin wheel should be placed at the inferior border of the 12th rib, approximately 6 to 8 centimeters from the midline. Then appropriate spinal needle. This is very important. I think you never mentioned what type of needle you will use. You went on saying that a long needle at what angle, at what depth, all that. But long spinal needle is very, very essential and advanced at a 45-degree angle from posterior to anterior towards the ventral surface of the T12 and the L1 vertebral space. until the vertebral body is contacted. Once the vertebral body has been contacted, the spinal needle should be advanced approximately another 1 centimeter in the prevertebral facial plane. Once the needle is in the desired plane, then you can confirm the position by CT or fluoroscopy. Then you give first a local anesthetic and give a diagnostic block. Then follow it up with a therapeutic neurolytic block. In the instance of the unilateral block, always left-sided approach. So we have to block both sides in majority of the cases, but many a times by just blocking the left side, the drug will slowly seep to the right side also and block both sides reliably. And a bilateral block can be performed if the unilateral block does not provide sufficient results. Now coming to the anterior paralytic approach, as she rightly said, patients who cannot lie in the prone position, they are the candidates where we have to do it in the anterior approach. And this approach is especially helpful in patients with advanced disease who may have abdominal discomfort or unable to lie in prone position, or those who have recently undergone abdominal surgery. They also won't be able to lie in the prone. And patient in the supine position, needle's trajectory is mapped with a CT or a fluoroscopic guidance. The skin is disinfected, prepared similarly. A local anesthetic wheel is injected, and then abdominal wall just anterior to the T12 vertebral body. An appropriate spinal needle should be inserted and directed towards the abdominal aorta. And the needle's course will be typically encountering a lot of abdominal viscera, including bowel, stomach, or liver. So it depends on the route that you take. With a needle tip in final position anterior to the aorta and diaphragmatic pleura, the neuralizing agent is injected into the antecoronal space. And the approach is often quicker than the posterior cardiac approach, well tolerated by patients. The use is limited by potential organ injury. So majority of the people who do the ear plexus block routinely, they prefer the posterior para-aortic approach rather than the anterior approach. Complications, all that she mentioned, can be so many things like orthostatic hypotension, muscular injection, nerve root injury, paresthesia, trauma, intraperitoneal hematoma, paraplegia. All these things are known complications. And there is always a failed block also can happen sometimes. Orthostatic hypotension, which is most common complication, is minimized with adequate hydration. And all monitoring gadgets should be used. Very, very important because the patient sometimes, will end up with a problem of functioning the aorta with the bleeding or some other hypotension. So full set of monitoring and you constantly keep in communication with the patient. Don't sedate them too much. Just keep in contact and keep talking to them so that you don't miss the patient's deterioration. So complete sympathetic denervation of the gastrointestinal tract, because we are blocking the sympathetic, causes the pain, the overactivity of the parasympathetic, which all increase the peristalsis, and that may. So this is the position of the patient lying in the face down, and this is the triangle. You have to mark this dorsal spine of L1 and then the 12th rib lower border. So when you connect all that, it becomes like a triangle, and this is the needle approach. So this is the L1 body of the vertebra. This is the spinous process. So we go 6 to 8 centimeters lateral from the midline, and then angulate the needle in a 45-degree angle. So this will be vertical 90-degree, and this is 180. So in between it will be something like a 45-degree angle. You first go and hit the bone here. So the first needle is coming and hitting the body of the L1 vertebra. Then you just pull it out and then redirect it in front of the vertebra. And here you have all the vessels. So in front of the aorta, you have to just go. And in this paragraph, as he rightly said, once you are very close to the aorta, it will start pulsating. So the needle will nicely pulsate because of the pressure, just like you do an axillary block. under pulsation technique, you can see the pulsation happening and aspirate for that, and then first inject the local anesthetic, make sure there is a pain relief, then give the neurologic agent and complete the whole thing. Okay, so these are the things that you can just remember for this answer. Right.
Any questions from students? Can we move to the next question, sir? 51.
Right, if there are any questions, you can ask at the end also. We will complete the that topic. What is the next topic? Anybody ready for that?